Hello and welcome. Today I'll be discussing diabetes. If you've heard that word before, I think you most likely know about diabetes mellitus. There are different types of diabetes. Diabetes mellitus is one of them. Diabetes insipidus, gestational diabetes, maturity onset diabetes of the young. But in this video, we'll be focusing on type 1 and type 2 diabetes, which is diabetes mellitus. I just need to mention that this video is going to be in two parts. The first part is going to be on definition, types of diabetes, pathology of diabetes, symptoms, diagnosis, and then the part two will look at treatment and prevention. So in terms of definition, diabetes mellitus, diabetes insipidus, both can cause polyuria, which is excessive passage of urine, although the mechanisms are different. In diabetes mellitus, we're talking about excessive amount of glucose or sugar in blood due to a problem with insulin production or function. Like I mentioned earlier, there are different types of diabetes, but our focus is on diabetes mellitus, particularly type 1 and 2. There is a gland in the body referred to as the pancreas. In the pancreas, you have the islet cells of Langerhans that produce insulin, particularly the beta cells. If, for example, there is an autoimmune disease process that destroys these cells, it will produce a type of diabetes called type 1 diabetes because the insulin production will be gone. And so, in those days, it used to be referred to as insulin-dependent diabetes mellitus. In other words, because the body is unable to produce any insulin, you've got to now bring in exogenous, that is, insulin from the outside into the body. When the body produces it, we refer to it as endogenous. Now the endogenous supply is gone because of the autoimmune disease that caused the problem. You've got to inject insulin, which is from the outside. And so we used to call it insulin-dependent diabetes mellitus, preferably referred to as type 1 diabetes. In the type 2 diabetes, there is inadequate insulin secretion. In fact, there are a number of mechanisms. One of them is inadequate secretion. The other is insulin resistance. And in resistance, what we mean by resistance, the fact that there is decreased transport of glucose into the muscle cells, and there is also elevated liver production of glucose. So there is resistance to the function of insulin. And then there could also be excessive or inappropriate glucagon secretion. Now, initially, remember I said that in the pancreas, you have the beta cells of the islet of Langerhans. These secrete insulin, but there are also other types of cells. Another type of cell secretes glucagon, whereas insulin reduces the amount of glucose or sugar in blood. Glucagon, on the other hand, increases the amount. So if for any reason there is excessive amount of glucagon, increasing the amount of glucose in circulation, at the end of the day, there will be a problem, and that problem could occur in patients that have type 2 diabetes. Therefore, in patients that are overweight, they could present with insulin resistance, and that's why obesity can be a risk factor for type 2 diabetes. And so, we used to refer to these as non-insulin dependent diabetes mellitus, but preferably you would call this type 2 diabetes. So, in summary for what I've said so far, just to summarize what I've said so far, there is a type 1 diabetes, there is a type 2 diabetes. In the type 1 diabetes, there's an autoimmune destruction of the islet cells of Langerhans, and so there is no insulin production. In the type 2, there could still be some insulin production, but there is resistance to the action of insulin. In terms of the age of presentation, the type 1 diabetes will typically occur in patients that are young or children, but in the type 2, more likely older adults. However, it's very important to mention that we do not use age simply as the distinction or as a reason for categorizing this condition, because sometimes you may find older people also requiring insulin, and so not to be confused about that, is just basically in terms of preponderance, you're more likely to find type 1 diabetes in patients that are either children or young, and then type 2 more likely to be in the older people. And then in terms of complications, people with type 1 diabetes are more likely to have what is referred to as diabetic ketoacidosis, and then in those in type 2, hyperosmolar hyperglycemic state. Now, we're not going to discuss that in this video, but just to mention diabetic ketoacidosis and HHS, or hyperglycemic hyperosmolar state. You've been hearing about insulin. So what exactly is insulin? Insulin is a hormone that lowers glucose level in the blood. Now, if you hear me say glucose or sugar, we can use that interchangeably. So insulin lowers the amount of glucose in circulation. So after you've had a meal, the body releases insulin to help reduce or lower that amount of glucose in circulation. What it does is that it simply helps to push this glucose into the cells so that it can be used as a source of energy or stored for future use. It's also important to mention that insulin is an anabolic hormone. What that means is that it helps to build up synthesis, growth. If there is a problem with insulin production or insulin action, the end point is hyperglycemia. So what is hyperglycemia? It simply means excessive amount of glucose in circulation. Now, this is where it becomes really quite interesting. How is it that a patient has so much glucose in circulation and feels weak or lacks energy? Sounds like a paradox. But the basic point is that as long as the sugar, the glucose, cannot be moved into the cell by insulin, the patient will feel weak. So it's a case of hunger in the midst of plenty. So what are the risk factors? What are the predisposing factors for this condition? Number one, if a genetically susceptible individual develops, say, a viral infection that triggers an autoimmune problem. An autoimmune problem is a situation where cells of the same person begin to attack the same other cells of the same body. In other words, self-attacking self. I made a video concerning rheumatoid arthritis, and I've quite clearly discussed and explained the concept of autoimmune disease. So it's a case where the self or body attacking its own self, so self-destruction. So if that occurs, the pancreatic cells, called the islet cells of Langerhans, can be destroyed or damaged, and so predispose the patient to developing type 1 diabetes. If there's the presence of other autoimmune disease, is a pointer that this person may also develop autoimmune disease of the pancreas, and so develop type 1 diabetes. And such autoimmune diseases include Graves' disease, which is of the thyroid, Hashimoto's disease, which is of the thyroid, and Addison's disease, which occurs in the adrenal gland, which is a small gland that sits on top of the kidney. Okay? Then family history. You observe that if somebody in the family does have diabetes, somebody in the next generation could also develop diabetes. And then age. Older people are predisposed to developing type 2 diabetes. Race and ethnicity. People of Asian, African, Afro-Caribbean ethnicity are at risk. Medications such as steroids used over a long period of time could predispose to diabetes. And then thiazide diuretics could be used in treatment of hypertension. For example, medication called Moderatic is a thiazide diuretic that we use in treating hypertension, but could predispose patients to developing diabetes or hyperglycemia, because one of the side effects of Moderatic is hyperglycemia. There is a video I've made, is diabetes or is hypertension a twin to diabetes? If you look out for that video, I'm sure you'll be able to learn a little bit more about that. And then number 7, obesity. Remember I said that people that are overweight are predisposed to having insulin resistance. And so because of the insulin resistance, they could have or be predisposed to type 2 diabetes. Alcohol. Chronic, long-term, excessive use of alcohol can damage the pancreas, developing chronic pancreatitis, and ultimately could also lead to diabetes mellitus. So these are risk factors. What are the symptoms of diabetes? There are 3 I want you to remember, and interestingly, these 3 start with P. Polyuria, polydipsia, polyphagia. I'll explain them. PPP. So if you remember these 3 Ps, then you most likely, even as a non-doctor, be able to diagnose diabetes to an extent. So the first P is polyuria, which is excessive passage of urine. One of the things that patients that have diabetes would initially observe is that they have to use the bathroom or the toilet quite frequently. And the reason why this occurs is that if you have raised amount of sugar in circulation, it pulls water. So where the sugar goes, the water goes. So as you have so much amount of glucose or sugar in circulation, it causes what is referred to as osmotic diuresis. So you now need to pass so much urine because of the increased amount of glucose in circulation. When this occurs in the daytime, you notice that you're passing so much urine, but could also occur at night where you wake up quite frequently, and that's referred to as nocturia. So that's polyuria, the first P. The second P is polydipsia. Now observe that if you're passing so much urine, at some point you become dehydrated and become thirsty, and you notice that you're drinking quite a lot of water. The third one is polyphagia, where you're eating quite a lot, and it appears, despite the amount you're eating, you're losing weight. So PPP, polyuria, polydipsia, polyphagia with weight loss. Why do people lose weight? With the amount of, a good portion, a substantial portion of our bodies is made up of water. So if you're passing so much water so frequently, you're most likely going to lose weight. In addition, remember that I said that insulin is an anabolic hormone. In other words, builds up. So if you remove what's supposed to build up, what will be the response? There'll be catabolism, which is breakdown. So you have muscle wasting and the person loses weight. Other symptoms, blurred vision because of what's going on with the raised glucose level in the lens and the vitreous humor of the eye, fatigue and weakness, despite the amount of sugar. Remember, we talked about hunger in the midst of plenty. There's so much glucose in circulation, but it's not entering the cells because there's either a lack of insulin or an improper functioning of the insulin. Peripheral neuropathy, where a patient develops numbness, tingling sensation. Possibly we'll do a video on that, so we'll leave that at that level. How do we then make a diagnosis of diabetes? The first thing is to ensure that we're clear about the different types, in other words, type 1 and type 2, because the treatment are not exactly the same, but could share a number of things. So the symptoms will help us. We've mentioned the 3 Ps, remember, polyuria, polydipsia, polyphagia with weight loss. And then the blood glucose level. The doctor may ask you to have what's called the fasting blood sugar, which is the first blood glucose you take before breakfast, or you could take at any point in time. But what we use is the reference range. If we have the reference range, you'll be able to tell whether your glucose has shot beyond normal in addition to the symptoms you are presenting with. But the problem with just using the blood test, like the fasting blood sugar, is that for one reason or the other, it may not give us the most accurate picture of what's going on. And so there's another test called HbA1c. Essentially what this does is that, remember, the red blood cell has a lifespan of about 120 days. So the HbA1c helps to tell what the average estimate or the estimate of your blood glucose has been over a 2 to 3 month period. This is quite reliable because irrespective of what you did 1 or 2 days before coming to the hospital, this gives us an idea of the average amount of glucose that has been in circulation over a 2 to 3 month period. In terms of making a distinction between type 1 and type 2, there are other tests that can be carried out. C-peptide, which I won't discuss much about, and then autoantibodies, which I also won't discuss much about. One of the things that can also be a guide is that if it can be controlled with diet, exercise, lifestyle changes, it most likely is type 2 diabetes. Type 1 diabetes will certainly require the use of insulin. And so in this video, we've looked at definitions, we've looked at symptoms, we looked at risk factors, we looked at how to make a diagnosis of diabetes. In the part 2, we will discuss the treatment and prevention. If you've learned something, like, share, and subscribe. Thank you.